Hello, welcome to Neuropsychiatric Aspects of Parkinson's Disease. We're glad that you can join us today. We are presenting today from Augusta, Georgia at the Medical College of Georgia. A few brief housekeeping items. If you are having trouble with the seminar software, check to see if Flash Player is enabled and if you have any pop-up blockers disabled. If you can connect to the seminar and the audio portion but get kicked off at any time, just reconnect using the instructions that were provided in your email invitation. This activity has been planned and implemented in accordance with the essential areas and policies of the Accreditation Council for Continuing Medical Education through the joint sponsorship of the Medical College of Georgia School of Medicine and the Georgia Statewide AHEC. The Medical College of Georgia School of Medicine is accredited by the ACCME to provide continuing medical education for physicians. The Medical College of Georgia School of Medicine designates this educational activity for a maximum of 1.0 AMA PRA Category 1 credits. Physicians should only claim credit commensurate with the extent of their participation in the activity. With that, I will now go ahead and turn over the program to our speaker, Dr. Laura Marsh. Dr. Marsh?
Thank you. My name is Dr. Laura Marsh. I'm an associate professor of psychiatry, as well as in the Department of Psychiatry and Neurology at Johns Hopkins University School of Medicine. There, I'm also the director of the clinical research program of the Morris K. Udall Parkinson's Disease Research Center of Excellence. It's a pleasure to be here today to speak to you on neuropsychiatric aspects of Parkinson's disease. First, to provide disclosures on my activities, I have served as a paid consultant or a member of the advisory committee or have received grant support from Acadia Pharmaceuticals, Boehringer Ingelheim, Merck Serono, Force Laboratories, Eli Lilly, the National Institute of Health, and Ovation Pharmaceuticals. This talk will describe use of medications for purposes that are not approved by the FDA for the treatment of neuropsychiatric disturbances in Parkinson's disease. First, to go over the learning objectives. We will be discussing the co-occurrence of psychiatric and cognitive disturbances over the course of Parkinson's disease, including before its diagnosis. I will describe the overlap of motor and neuropsychiatric features in Parkinson's. I will go over the common subtypes of neuropsychiatric disturbances in PD, and I will review the general treatment approaches to neuropsychiatric disturbances in Parkinson's disease. Parkinson's disease is a neurodegenerative disorder that is fairly common. It affects about 1 million Americans with an increased prevalence as the population ages, affecting 1% of the population over age 50 and up to 4% over age 80. It affects all races and ethnicities, and more recently, with celebrities being affected by Parkinson's disease, more attention has been called to the motor aspects of the disease. However, there still is a need for better recognition and treatment of the neuropsychiatric complications of Parkinson's disease. So one way to approach that is to first go over a patient's history, which in many respects illustrates almost every problem that one could have with Parkinson's disease over the course of the illness. And this is a patient who I have taken care of, who was born in Italy in 1950. And interestingly, she had her first motor symptoms of Parkinson's disease at age 46. This began with right leg stiffness, a change in gait, she was tripping, and later she had a right hand rest tremor and clumsiness, as well as right foot dystonia. However, Parkinson's disease wasn't diagnosed, and it was not really clear to others why she had these symptoms. At this point, she was living in America. She emigrated here when she was a girl. 3 years after the onset of her first motor symptoms, she had the onset of a depressive episode. And she was treated by her primary care doctor with fluoxetine. She again had a second depressive episode in 2001 because she had stopped the fluoxetine on her own accord. It was around that same time that she had the onset of cognitive symptoms, which she described as decreased short-term memory, distractibility, not completing tasks, being disorganized, and slowed mental processing. Symptoms that are often described under the overall heading of executive dysfunction. 6 years after she had the onset of motor symptoms, she was diagnosed with Parkinson's disease. And at that point, she was started on an antidepressant for her depression, which improved her depression, but she was also started on a medicine for her Parkinson's disease, pramipexole or a dopamine agonist. Shortly after starting this combination of medicines, she developed auditory and visual hallucinations. Her pramipexole was therefore discontinued, and she was changed to levodopa as well as ropinirole, which is another dopamine agonist. Within the first year after being on these medicines, she had her first hypomanic episode. This resolved after citalopram was stopped and the ropinirole was reduced. She continued on levodopa. She then stopped her, after stopping her citalopram, she had another episode of depression in 2004, and she was treated then with escitalopram. Again, she had another hypomanic episode, which was improved when the escitalopram was reduced. She went on to have more pronounced cognitive deficits, and these were becoming increasingly problematic in her job as a school teacher. At this point, she described her symptoms as, particularly the problems with attention and distractibility, as being similar to a person who has attention deficit disorder. So she took part in a clinical trial that I will describe in a separate talk on treatment of executive dysfunction in Parkinson's with atomoxetine, which is a treatment that's been approved for use in attention deficit disorder. And she found that she had better short-term memory, she was less distractible, and became more organized on the atomoxetine. However, on the atomoxetine, she developed a third hypomanic episode. That, again, improved with reduced atomoxetine dose. About a year later, she then had the onset of what we call emotional incontinence or pathological tearfulness. This started after her escitalopram was reduced, and then she had another episode of depression. The escitalopram was increased, her depressive episodes were remitted, and she remained employed as a teacher, and she continued to be moderately affected by her Parkinson's motor symptoms, but they were really not the biggest problem for her. It was these neuropsychiatric complications. Finally, in the last year or so, she's had increased motor symptoms. So she's now 12 years into her Parkinson's disease motor symptoms, and she's having more problems with motor symptoms, in particular freezing or akinesia. So her ropinirole was increased, and along with that, she had more and progressive cognitive dysfunction, as well as emotional lability. Her ropinirole was tapered, her levodopa dosing was modified, and she was beginning to struggle in her marriage because of just difficulties coping with both her disease and trying to work as a teacher, and trying to minimize the impact of her illness on herself and her personal life. So her family participated in illness education, and this helped them both considerably. In the last year or so, she's also had increased cognitive dysfunction as well as emotional lability. She has had a relapse of her depressive episode, and she's now taking early retirement and going on disability 13 years after the onset of her Parkinson's disease. So with this patient, you can see that she really has had many motor symptoms as well as neuropsychiatric symptoms of Parkinson's disease. But when you look at the original descriptions of the disease by James Parkinson in his essay on shaking palsy from 1817, you can see that he described the motor aspects of the disease in a manner that really still rings true today. What he described was the involuntary tremulous motion with lessened muscular power, in parts not in action, and even when supported, that's the resting tremor, with a propensity to bend the trunk forward, the hunch posture, and to pass from a walking to a running pace. That's the fascinating gait that we see so often in a patient with Parkinson's disease. But categorically, he stated in this essay that the senses and the intellect were uninjured. So for many, many years, these neuropsychiatric aspects of the disease were really not recognized. Although when you read his essay more carefully, you will see that a number of the patients actually did have neuropsychiatric features, which he described, but were just not highlighted as an aspect of the disease.